And there we go. All right. So again, my name is Maddie Curry. I am a public health policy and programs coordinator. I'm an enrolled member of the Blackfeet Nation. And I obtained my master's in public health from the Colorado School of Public Health, and my concentration was in maternal and child health. So this is a topic that is very near and dear to my heart, obviously. So we need to understand, oops, excuse me. American Indian and Alaska Native women are face higher maternal mortality rates than other women in the United States. And we need to understand why this is happening. And why is it just gaining attention now at the national level? And a couple of the reasons why is the relatively small sample size of Alaska Native and American Indian women have prevented this issue of maternal mortality in Indian country from gaining national attention. And then there's also minimal research on the factors that are related to poor delivery and birth outcomes for women. We know that Native people make up 1.3% of the current population, I believe, but Native women face rates are the second highest rates of maternal mortality, and that is not acceptable. So some overview of the statistics. The pregnancy-related mortality ratio for American Indian and Alaska Native women is 29.7 maternal deaths per 100,000 live births. American Indian and Alaska Native women are 2 to 3 times more likely to die of pregnancy or birth complications than white non-Hispanic women. And also preterm labor and obstetrical hemorrhage rates are 2 times higher than white non-Hispanic women. And if we can see over time, it seems like the rates are going down and the ratios are going down, excuse me, but they're still the second highest compared only to Black women. And that is still, not acceptable that these rates are still so high. Oh, I'm sorry, excuse me. So we have to think about these adverse maternal health outcomes. And from a public health lens, we can think about these, and they're partly due to social determinants of health. And those are the conditions or places in which people live, work, learn, and play that affect a wide range of health risks and outcomes. And while social determinants of health do play a large role in public health thinking, in the Native context, we must also include historical trauma and systemic barriers that play, and those are 2 key factors that play a role in maternal mortality. So we can see that, and I'll go into this a little bit, but historical trauma can lead to poor behavioral health outcomes, increased substance use disorder, interpersonal violence, mistrust of healthcare providers, and increased risk for trauma exposure. Systemic barriers are things like poverty, food insecurity, U.S. healthcare system, insurance being really complicated, which can limit access to achieving care. And then also the rural reservation locations, which I'll get into, increases limited access to healthcare services. All of these things lead into risk factors, which are, the things that directly affect a woman and her pregnancy. And those can include hemorrhaging, hypertensive disorders of pregnancy, and then exacerbated pre-existing conditions. I just want to make sure I cover everything on this slide. So as we think about these social determinants of health, we always have to consider historical trauma when we are considering maternal mortality prevention. And historical trauma was a concept and theory developed and synthesized by Maria Yellowhorse Braveheart. And it's a massive cumulative trauma across generations rather than the more limited diagnosis of PTSD, which is inadequate in capturing the influence and attributes of Native trauma. The historical trauma of genocide, reproductive coercion, cultural erasure, forced sterilization, all of these things that have only ended and very, very recently have all led to forced assimilation by the United States government, led to the breakdown of tribal social structures. High levels of behavioral health problems have also been a result of historical trauma. This can include substance use, sexual and personal violence, as well as the history of forced sterilization and separation causes mistrust between Native women and their care providers, which makes it hard to establish the important relationship that's needed for growing, delivering, and caring for a healthy baby and their provider. So all of this snowballing loss of culture, language, spirituality that was impacted on us by the colonizer, the United States government, has led to a breakdown of social structures and this increased risk for trauma exposure and increased risk for maternal mortality. In addition, with historical trauma, we also have to consider systemic barriers when we are talking about maternal mortality and also overall Native health. We know that Native people were placed in areas that are considered invisible to the rest of the country. And you can see based on this map that Native people still are in the least accessible areas of the country. This has led to extremely high poverty rate. 26.7% of Native people were living in poverty in 2017 compared to 10.5% for the rest of the population. Food insecurity, which leads to the obesity paradox. In 2016, almost 40% of Native peoples on a South Dakota reservation were food insecure. Access to health insurance. Native women are 2 times more likely to not have health insurance than non-Hispanic white women. Minimal and zero access to specialty OBGYN services and low physician retention rate means that women who have more complicated pregnancies aren't going to be able to get the care that they need. And, the cities that have more complicated and complex biomedical systems and healthcare facilities are very difficult to access based on what we're seeing in this, based on how our reservations have been set up. And, systemic barriers are these policies and programs and practices that unfairly discriminate against specific populations. So Native people, they're often historic and were put into place without consideration for the Native people. So we can see visually a systemic barrier, is the rurality of reservations. And just again, I want to reinforce how limited access to more complex treatment would be for someone who is needing those services. So with historical trauma and with systemic barriers, there are some identified risk factors that are contribute to maternal mortality. So the leading cause of pregnancy-related mortality is hemorrhaging. This is cause-specific, so this is something that can be identified post-mortem. And other more nuanced causes that might be more related to the social determinants of health, they might not be accounted for just due to a lack of data. And this is something we'll discuss again as we get deeper into this topic. During pregnancy, risk factors can be also, gestational diabetes is a large risk factor, hypertensive disorders of pregnancy, including preeclampsia, and also pre-existing hypertensions can be exacerbated. And some social determinants that could be related to this are, for example, food insecurity and higher poverty rates. And again, the rurality of reservations. Okay, and then again, some more risk factors for maternal mortality in Indian country is, again, like I spoke about, the systemic barriers of healthcare access and late entry into care. So, for example, 41% of Native women don't attend the recommended number of prenatal visits. Again, we have to understand or ask what is wrong with the system. So why aren't these women being able to access those prenatal visits? And also the low physician count in IHS healthcare. There's a 45% of physician vacancy rate just overall in IHS, and just the overall consistent underfunding of IHS healthcare is an issue. Also, lack of insurance, the complicated insurance systems can be intimidating, and poor access to healthcare services. Like I said, there's extremely limited amount of birthing facilities in Indian country, and transportation from extremely rural areas is sometimes impossible. Again, navigating these complex healthcare systems can increase maternal mortality and maternal health effects. So while those are a lot of really not the best things to talk about, we do also have protective factors. We have conditions or variables that are capable of directly affecting us and increase the likelihood of positive health outcomes for us. It's essential that we identify these protective factors at the individual, the relationship, and the community level, so we can recognize ways to leverage factors and promote maternal health. So for example, we all know that community support and having a close relationship with your family and tribe, connecting to your culture can increase your positive self-image. Having, strong education, being involved in school and developing those friendships, just all those things contribute to positive mental health and self-esteem, which helps to promote overall health, not just maternal health, but overall health. So now that we have some context, again, a very umbrella overview of maternal mortality, I will let the subject matter experts get into more of the nuances of maternal mortality and maternal health in general later. But I just wanted to give a brief overview of what we're doing to help now. So we have been working to explore the idea of developing tribal-led maternal mortality review committees as a potential tool. We've been working to explore the feasibility for tribes to adapt the current maternal mortality review committee model to their needs through the development of several tools created by NIHB in tandem with subject matter experts. So just really briefly, colleagues at CDC will get into this next, but maternal mortality review committees are multidisciplinary committees that perform comprehensive reviews of death among women within a year to the end of a pregnancy. They can include representatives from public health, obstetrics and gynecology, maternal and fetal medicine, nursing, midwifery, forensic pathology, mental and behavioral health, patient advocacy groups, and community-based organizations. So the Centers for Disease Control, the CDC, works with MMRCs to improve review processes that then inform recommendations for preventing preventing future deaths, excuse me. MMRCs have shown that 2 out of every 3 pregnancy-related deaths are preventable. MMRCs, as of right now, only operate at the state level. And while there are 6 state-led MMRCs that have active tribal representation, there are no tribal-led MMRCs. So why are we thinking tribally led? Why can't we just incorporate tribes into the pre-existing state-led MMRCs? Well, it's because tribes are sovereign nations with distinct needs and governance, and NIHB will always work to uphold the sovereignty of tribes. Tribes, again, also have specialized community-driven strengths and assets to improve maternal health outcomes. Those protective factors that I just spoke about, for example, community support and connection to your culture. And then there's also the need to address historical trauma and structural racism and the risk factors that result in those that are and throughout all tribal communities. And we also need to recognize that all tribes are different and unique, but there are some commonalities that we can all, have that we can all have. And one of those is tribal sovereignty. So over the past 2.5 years or so, the overall goal of our tribal-led MMRC project is to support tribal nations and regional tribal organizations in exploring the need and feasibility of creating a tribally led maternal mortality review committees. NIHB is creating a tool and opportunities for tribes and regional tribal organizations to self-assess their potential ability and capacity for implementing a tribal-led MMRC. So for year one, which was 2019 through 2020, there was a 1.5-day meeting at the California Rural Indian Health Board with 11 tribal maternal and child health subject matter experts. Some of you might actually be here today. And the group brainstormed 4 possible models of what a potential tribal-led MMRC would look like. Again, upholding tribal sovereignty, making sure that tribes have the capability and the ability to implement and establish an MMRC at whatever level they might need and for their capacity. So these are the 4 models. So these were developed out of this meeting, and the first model is tribe-specific MMRCs. So individual tribes would be able to establish MMRC and review all maternal death cases in their defined community. Some pros of this is, it empowers tribes to serve and protect their mothers, but for some cons are for smaller tribes, this might not be feasible due to the low case counts. Not saying that that's an issue. The second model is an area-wide MMRC. This would encompass the IHS, the 12 IHS regions, and they would be operated by the area and in health boards. The pros, we could utilize tribal epidemiology centers to have data to support MMRCs, and resources can be pulled together within an area. Some of the cons is it might take longer to establish a committee, and also the turnover in tribal leadership might also have encounter some speed bumps. The third model is blended tribal state MMRC model, and that is utilizing established state-led MMRCs with the addition of tribally led subcommittees that could handle AIAN cases. And a pro for this would be the subcommittee could decide who reviews cases, again, upholding tribal sovereignty. And a con could be that, tribal voices might be suppressed by states which are have been shown to do that in the past. And then the fourth model is a national MMRC, one national tribally led MMRC that would review all American Indian and Alaska Native maternal death cases. The pros for this would be a large number of cases would allow the committee to meet more often, but then there would also be unclear authority on gathering medical records and death certificates from each state. And these 4 models are just, again, options for tribes to be able to choose as we move forward with implementing or developing MMRCs, what model might be best for each tribe or tribal health consortium. So for year 2, now we have an idea of what these maternal mortality review committees might potentially look like in the context of native maternal mortality prevention. Now our goal was to create a logic model for developing a tribal-led MMRC, and a logic model is just kind of a flexible roadmap that we use to guide us and identify key priorities and make sure that nothing is getting left out. And so we teamed up with a group from Harvard for a practicum, and to develop this logic model, we made sure we held the guiding values of respect for self-determination and tribal sovereignty, and the respect for diversity, values, and history of tribal communities. Our students, as they developed this logic model, had these guiding questions of what are the barriers and facilitators of a tribal-led MMRC, and then also how can MMRCs function in a way that center tribal voices. With the stakeholder engagement of 19 stakeholders that included tribal members, researchers, service providers, and clinicians, we as a team were able to create a logic model for the next 5 years or so. Again, and this is a flexible roadmap. Logic models are a great tool in that they're not set in stone, and they are meant to be molded as the programs develop. So as you can see, we have 5 key priority areas that we have deemed essential to consider when you are developing a tribal-led maternal mortality review committee, and that is community relationships, staffing, logistics, and data. And all of these things are essential for guiding your maternal mortality formation. And understanding and meeting all of these things will hopefully result in a successful capacity for facilitating and maintaining a tribal-led maternal mortality review committee. And from this guiding logic model, I know it's a lot, and these resources will be online after the institute is over. We from this adapted the logic model as a guide for tribal-led MMRCs. So this can kind of serve as your roadmap if you are looking to potentially do something like this to review and support a tribal-led MMRC. You can have your inputs and your planning, and then what you need to do to take action, and then how these things can be maintained over time, and hopefully the priority areas that these activities and outputs will affect. So again, these resources will be online for you to look at. And please, again, reach out to me if you have any questions. But these are the guides that we developed. So then with year 3 now, which is what we are in right now, we have come up with a goal of facilitating self-assessments with tribes and tribal organizations to assess the feasibility for developing and implementing a tribal-led MMRC that's continuing to respect Native culture and result in meaningful and effective prevention strategies for Native communities. We've been working, and over the last year or so, worked to create a self-assessment tool for a pilot cohort of tribes to evaluate the feasibility of them implementing a tribal-led MMRC. And those 3 awardees are the American Indian Health Commission of Washington State, the Santee Sioux Tribe of Nebraska, and the Peoria Tribe of Indians of Oklahoma. And we usually give project updates around every half year or so. So next time we meet, hopefully all together again as a community, and we will continue to give project updates as where we are going with this. And so for next steps, as we continue with this year, we're building our peer learning network. This is one of the first spaces to serve as that, as to build us up and promote this issue on a national level. We're also working to build our online resource library so people can have a space to go to learn about this issue. And then, as Stacey mentioned in the beginning, NIHB, we serve to advocate for the tribes and policy change, and we will be continuing to do so as policy is being passed through. So I know I'm a little bit ahead of schedule, but I just wanted to say thank you. And let's see, I guess I can open it up for Q&A right now, unless, yeah, I can. Let me just take a pop in the chat and I'll see if anyone has any questions. Okay.
Maddie, if I can jump in to one of the items in the chat. And hi, everybody. My name is Nina Martin. I'm a program manager at NIHB and work very closely with Maddie on our maternal health work. So I just wanted to note that earlier on, somebody had put a comment about, as Maddie brought up some of the statistics on physician vacancy rates, focusing on high rates of certified nurse midwives. And that is definitely something we're curious to hear more about, including tomorrow. We have some space to hear from folks who are working directly with families and patients and really figuring out how we can center systems on the needs of Native mothers and responding to their concerns. And so we're very curious to hear more about how, what are some ideas for the tribal birth workforce that focuses on cultural competency and really reflects the ways and the needs that tribes have to serve their mothers and at large their communities.
Thank you, Nina. I really love, again, all of these considerations. As Nina said, this is really a learning opportunity for us as well. This is an opportunity for collaboration, and we are certainly not the experts. So we just serve as the platform. I want to open it up. Does anyone have any questions? We are ahead of schedule. So if you would like to unmute yourself or pop your question in the chat, we'll leave it up for about maybe 5 or so minutes, and then let's see, check in with Toby and see.
Hi, this is Dr. Ward. Hi, can you hear me? Yes. Hello, this is Dolly Lane. Can you hear me? This is Dolly.
Yep.
I have a question. So what's the data or statistics or demographic that supports this program? How did this program started? Is there a lot of mortality? Because at our hospital here in Tuba, we don't get a lot of, we don't get any of that information. I'm a board member, and I think I'm going to be asking for some data on